May I invite Dr. V.P. Goswami sir, President NNF, to come on to the dais. May I invite Dr. Lanan Bharti sir, President NNF, through the flagship of all the latest knowledge. Thank you very much, Chairperson and the Speaker. Ladies and gentlemen, it's our tradition to conduct the oration year after the year, every year. We'll move on to the oration. May I request the President of NNF, Telangana State Chapter, Professor Dr. Alimelu Madam. May I request Secretary of Telangana State NNF, Dynamic Dr. Preetham, with all his rainbow full of colors. Dr. Karthik Nagesh, he has come all the way from Bangalore. We are conducting Nagaraja Rao sir's oration.
Today, standing in front of you for the Dr. Nagaraj Rao sir's oration, and I am so emotional because I've been sir's student as well when sir was at Nilufar, and I also worked with him in a private hospital for some time before he actually went to US, and unfortunately he had expired there. So he had always been very encouraging, and it is my proud privilege to read about sir. He was an academician, a thorough gentleman and a great teacher, a clinician par excellence. He was poet, and he's written several books on that. And he was born during 1934, 16th August at Anantapur. He did his MBBS from Usmania Medical College in 1958 and DCH from Nilofar. And it is 1960, he did his MD from New Delhi, AIMS. He was awarded FIAP in 1987 and Fellow of National Academy of Medical Sciences in 1999. He worked for 30 years as Assistant Professor of Pediatrics and subsequently worked as Professor of Pediatrics at Kakatiya Medical College and Nilofar Hospital. I was fortunate to meet him there. His neonatology was really very close to heart. He really liked to attend even calls at a very late age as well. So sir was an expert in that. He was the founder member of NNF at the national and state level. He had various positions in state NNF, including as a coordinator, president, and advisor. He was also the governing council of the NNF at the national level. He was the organizing secretary of NEOCON 2003. His contributions were widespread, and he always taught about the importance of good neonatal care, he went around many districts in Telangana and AP, United AP, and did several NRP workshops. He's authored number of books in pediatrics and contributed articles to many, many pediatric textbooks and journals. He has 3 books containing his poems to his credit. He passed away in USA on 14th November. He survived by his wife, Srimati Geeta, and his son, Harish, Rahul, and daughter, Aparna, and grandchildren. So, thank you.
Good morning, all of you. It's an honor to introduce Dr. Karthik Nagesh, who is the chairman and HOD of Neonatology, Manipal Hospital. Sir has started a lot of courses both in Manipal. He's almost established the 3-year DNB program, and he's been examiner inspector for DNB neonatology, and sir has been teacher for almost now 20 years, and he's got varied publications, almost close to 100 with different chapters in books, and he's got a lot of awards as well, and he's been awarded the FNNF also. So now I hand over the proceedings to Dr. Karthik Nagesh to deliver the MN Rao oration.
And a proud privilege to be bestowed this oration award of Professor Nagaraj Rao. I distinctly remember Professor Nagaraj Rao in the 2003 NEOCON when he was here, a very humble person, full of humility, and he conducted the NEOCON in one of the best NEOCONs which was held in the city of Hyderabad at the time. It's always a pleasure to be coming to Hyderabad, and I'm so grateful to the organizers, and especially to Dr. Jagdish Chandra, Dr. Indrasekhar Rao, and the other organizing committee of this conference for having bestowed this honor upon me. I have a lot of people to thank, my parents and some of my teachers. Two of them are in front of me here. I'm honored to see Professors S.K. Bhargav and Professor Ashok Devrari. Thank you very much, sirs, for having made me what I am today. This day is also dedicated to my family and so many of my colleagues and so many of my patients who have been supportive. One person missing in this picture is Dr. Arvind Shenoy, who is here sitting in front of me, who has been with me for 18 long years before he moved on. He has been a great influence in my family. You can't talk about newborn care in this era today unless we talk about intensive care and what has happened to intensive care in all these 40 long years. It's been a journey of about 40 years for me, and luckily, some of the people of my vintage have been able to see what has happened in the growth of newborn intensive care in this country and how smaller and sicker babies are now living. And it has been a journey of learning, and currently, if you were to see in this country, there are at least about 1,000 newborn units providing good quality care, so that even the smallest of preterm babies, less than 1,000 grams, are able to have a good survival rate in resource-rich institutions, both in the private sector and in the government sector. Close to almost about 70 to 80% survival, and most of them is intact survival, as follow-up studies have shown now. Much of this is to do with a lot of hard work neonatologists in this country have done in terms of trying to develop protocols, systematization, infection control. Nursing especially has been our greatest strength in this country, and quality improvement initiatives. But I'm going to focus on one aspect, which is the respiratory care, which has evolved so much, especially in this last so many decades, of which almost 3 decades I've been part of trying to look after babies in this country. There has been a paradigm shift in the way we look after babies in today's world as compared to 3-4 decades back. We have always been trying to adapt newer technology and newer influences on us by great teachers like Satyan, who just spoke before me, and trying to see what it takes us better to do good for these babies. Many of my young students to whom I spoke to just about a couple of days back before I embarked upon deciding what to talk upon, they have not heard about the way respiratory care has happened in preterm babies, especially in the decades before. We have seen a paradigm change in the way respiratory care has happened in the last 40 years or so. Most of it has been a great learning exercise for me of my vintage. We started initially 30 to 40 years back with provided good clinical services. During this phase, some research also came along, and recently a lot of youngsters we are able to train and deliver the goodness which we have learned in our careers, and they learned from our mistakes. We have always been trying to learn also from great teachers who are sitting in front of me, and teachers in the morning you have heard from conferences like this. And I would say I'm basically a student still at heart, a student of neonatology, and there's been a great lessons I've learned all these years. Luckily for me, whenever an oration like this is planned, we have to talk a little bit about the journey you've been through and probably delve into something more which is newer. Luckily for me, it has merged into being together. I have learned along these last 3 decades of actively providing newborn intensive care what is newer nuances of treatment in this field, and we have adapted to that, and I'm going to share with you some of the things we have learned. 20 years before we started doing neonatology in this country of the intensive care nature, people in the Western countries had already started ventilating babies after learning that surfactant was deficient in the baby's lungs, which caused them to have hyaline membrane disease. Ventilation was introduced even about 20 years back before, and then surfactant, multiple clinical trials were done in the mid-80s, subsequently proving that surfactant does work, and it's a good panacea for cure for RDS in HMD in babies. More than 40,000 babies were treated before it came into clinical existence. But then, I belong to a vintage of the pre-ventilation era when, as a medical student in the late 70s, I would see oxygen being delivered uninhibitedly to babies. Whatever modalities you could use, you would give a lot of oxygen to the babies. We felt good about giving oxygen to babies, not realizing in today's world, which we are very aware that it can be toxic to the babies. Oxygen monitoring at best started in the mid-80s or so. Pulse oximetry came about only in the late 80s, and we were one of the very first few ones in All India Institute, and I was working with Professor Meherban Singh to start pulse oximetry, and we thought it was expensive technology, and we would also use FiO2 monitors, which would deplete very soon with the galvanic cells it had, and that was the maximum we would do about oxygen monitoring. The first forays into newborn ventilation happened in this country in 3 good government institutions at that time, 3 good teaching institutions at that time, the PGI Chandigarh, All India Institute, and Safdarjung Hospital, all doyens of neonatology, Professor Bhargav, Professor Meherban Singh, along with Dr. Bakhu and Dr. Paul and Devrari. They are the ones who initially published most of the initial work on ventilation in this country. I had the fortunate exposure of working with all these doyens of neonatology who have been great influences in my mind, in my life. After having done my MBBS career from Maulana Azad Medical College, I had the fortune to do my MD in PGI Chandigarh, Professor Walia, Professor Bakhu, Professor Narang. Subsequently, in the great institutions of Safdarjung Hospital, I was a senior resident, started by Professor Bhargav. Subsequently, you see this young man sitting there is Dr. Devrari. I used to work with him as a pool officer for some time, along with Dr. Meherban Singh and Dr. V.K. Paul. These were the great influences which these visionaries had the inspiration in me to do newborn care in this country. But I felt there was something lacking there. We were ventilating babies. We were ventilating babies with those awkward ventilators which are pressure controlled those days, but we are not really doing ventilation. I felt something was wrong. I remember distinctly, both in Safdarjung Hospital and in PGI Chandigarh, if a baby was on a ventilator, which I'm sure Arvind Shenoy will remember, we were all trainees at that time in pediatrics, we would say, oh, this is a baby on a ventilator, this child there has to be a resident separately posted for a ventilator, because ventilation is something big. And still, the babies may or may not survive. So at that time, unfortunately, in the mid-80s, there was no active neonatology program in this country. With the blessings of my teachers, I went off to the UK to train further. My mentor was Professor David Harvey and Dr. Neena Modi, who till recently was the president of the Royal College of Pediatrics. Learned the nuances of ventilation. I could actually see babies surviving and coming out, and I could see a good follow-up on them. Learned a lot about what's this surfactant, what is this new, the surfactant replacement therapy, which is available now, and came back. The desire to come back was very strong in me. I didn't want to continue. At the same time, I heard a lot about this surfactant being used, and I thought I should bring all this technology, ventilation surfactant, to this country, and came with great expectations. Unfortunately, did not get a good placement in a government institution. I wanted to be in PGI Chandigarh or All India Institute. That is my hometown, Delhi. I did not get any placements. I had to make do with a private institution called Manipal Hospital in Bangalore, which gave me some space, just the 4 walls of a big room, saying, you start what's called newborn intensive care. We don't know what it is, but they were very, very kind enough for me to start newborn intensive care. That was a great concept at that time, which was in my mind. But mind you, I had taken the hard path. The challenges were very severe. There was an arduous task in trying to set up a newborn intensive care those days. Before me, in that era, in the private institutions, only 3 or 4 centers existed, and we had a great challenge at that time to start right from scratch, and especially regarding nursing training, resident training. Residents had not even seen a ventilator at that time. I had half a resident given to me, and nurses who had no clue about what ventilation or newborn care was all about. We started even educating pediatricians in the periphery and obstetricians, trying to ask them to send babies safely. We instituted a safe transport system. As we discussed earlier, we started what's called the NALS program, started educating people what is newborn intensive care all about. So this was the pre-surfactant era. I had been exposed to using surfactant, but look at this baby, 1992, case 1. This baby is an outborn, 1 kilo baby, 28-weeker, no antenatal steroids. We had not heard about antenatal steroids at that time. The baby was transferred with just oxygen to us from another hospital, came to us with this absolutely hypoxic, acidotic, had a great, we had a very stormy course in the intensive care, was ventilated for nearly 4 weeks, had a PDA which needed ligation. The baby would not come off oxygen for another 6 weeks, and finally, after a burst abdomen due to necrotizing enterocolitis, which was again treated, the child went home at 60 days. But I don't know what we did good with this child. This child is now 27 years old and is a practicing lawyer. She's doing amazingly well. But this is a baby with a grade 4 RDS those days. Those were the days we had no clue that what we thought using pressure-controlled, time-cycled ventilation was great, but we had no clue that we are damaging the baby's lungs. All we needed was to get this lung opened up. We wanted just the compliance to improve. We heard that lung compliance is poor in HMD. You need to open up the lungs. You needed a lot of close monitoring. With a pressure-controlled ventilation, we needed to watch the baby 24/7, all the time be at the bedside of the baby, trying to see whether the baby would need more and more or lesser and lesser of ventilation. It was hard times. As many of my colleagues in the same vintage would agree, these are hard times where we were probably doing more harm to the baby than good, but nevertheless also hard on us because we would be closely all the time having to monitor these babies, scared of barotrauma and other complications. This was also the time data emerged, though we were very difficultly able to procure journals because the internet was not there those days. For that matter, even mobile phones were not available those days. But we came to know that surfactant is now approved. Some countries in the world, including nearby countries like Singapore and Malaysia, it was available, but not yet still available in this country. It reduces mortality. It reduces the risk of air leak syndromes. So we thought we should try to get it. Survanta was the product which was initially available. But then, the first time when we needed this baby to be given surfactant was soon in the end of 1993, a very, very precious baby born at 34 weeks, severe RDS, an AA ratio which was less than 0.1, and this baby needed to get surfactant. We contacted colleagues in Singapore, friends who could fly in the surfactant for us soon, but by the time we gave surfactant, the first dose and the second dose to this baby, it was too late and the baby was gone. The baby had just died. This was lesson number 2 learned, that we have to give surfactant if at all early and not delay it too much. And this baby unfortunately succumbed. But then the next baby we got the opportunity was in late 93 again, and we already had procured some surfactant available at that time. The baby's parents were fairly well to do. They wanted to do everything for this baby. 1 dose of surfactant and the baby remarkably did well. It was like a wonder drug for us, a miracle drug for us. Please remember, in today's world, you're seeing things which are happening easily, especially the youngsters in the audience. It's all available, it's all ready, you just have to do it, data is available, you do it. But that's not the case. As Professor Bhargav and Dr. Devrari would agree, our times, it was all difficult to get all these things done, but nevertheless, this child is doing very well as well. So this was something we wanted to publish, and this published the first work of surfactant. In August 1994, we published it in Indian Pediatrics. It definitely showed that it reduces oxygenation, it reduces the need for ventilation, and babies come off the ventilator very soon after having given surfactant. Soon thereafter, there was a plethora of inquiries about wanting to give surfactants. Lots of neonatologists wanted us to do workshops. My colleagues, Arvind Shenoy, Professor Swarnarekha, Professor Maya from NNF Karnataka, we got together. We used to do a lot of ventilation and surfactant workshops in the mid-90s and late 90s and teach people that it's surfactant which is not the only reason babies survive. It's the whole concept of doing intensive care, the whole concept of trying to ventilate babies, that is what saves babies. Surfactant is just an add-on. During that period, we tried our best to get surfactant from whatever resource which we could get. Colfoceryl palmitate, known by ExoSurf, was mid-90s, it was available. Professor Walker Long visited my unit and got somehow arranged for colfoceryl palmitate to be available with us. But we found even at that time, that was a lesson to us, that synthetic surfactant, somehow, there was no data available, but that was the only surfactant available to us. We found at that time that that doesn't work as good as Survanta. So, subsequent to this, 1999, Survanta started becoming commercial, properly available in this country, and soon there was a plethora of data. Our own data got published. PGI Chandigarh, Professor Narang published and showed that surfactant improves the ventilation need it lessens the ventilation need by 45%. The cost also, you give 1 dose of surfactant, you may reduce the cost by 25% to the patient. So that was another great thing for us. People started getting reimbursements. It was available in the government hospitals, and our own data suggested that a single dose of surfactant could work in these babies as well, and good. And we had to we presented it in the NEOCON as well. But then, during this period, we were all excited and gung-ho about ventilation and surfactant. We missed one important thing. Antenatal steroids, NIH recommendations came in 1994, not many takers. I couldn't convince my obstetric colleagues enough to give antenatal steroids. It was only towards the end of the 1990s they could get convinced about giving antenatal steroids. So look at this, what happened as a fallout. We started getting referrals. We became a major referral center. So also 10 to 12 such centers in this country became major referral centers. Professor Devrari and Professor Mehraman Singh wrote this article in Indian Pediatrics. I remember in 1995, the status of NICUs and ventilation in this country. At that time, close to about 10 to 12 of our centers in this country were ventilating. We provided our data to All India Institute, which published it. So babies came pouring into our NICU. Even pre-viable babies, those days viability was 28 weeks, pre-viable babies started pouring in. Mind you, everything wrong was done for babies like this. Antenatal steroids had not been given. Baby had severe grade 4 RDS. The pediatrician who referred this baby had intubated and was giving ambu bag ventilation with an adult ambu bag, saying that's the only ambu bag he had. It's absolutely wrong. In today's world, you would not do that. The baby needed subsequently almost 3 months of ventilation on high mandatory ventilation with us. The child still was given surfactant by us. It didn't seem to make a difference to this baby. The baby had a significant PDA which got ligated at 1 month of age. The child stayed oxygen dependent for 8.5 months. I didn't even know what was going wrong. And mind you, at that time, there was no CPAP. There was no concept yet in this country about CPAP. So we are just giving oxygen to this baby. The child's lung was probably not getting recruited enough. We didn't know what to do. The parents were well-to-do. They said, shift us anywhere. They offered, can we go to America? I got the baby. I myself air transported this baby. This is probably the first few air transports we did at that time. And shifted the baby to a NICU in America, where the baby again, as soon as I reached the NICU with the baby there, they just ventilated the baby again, saying, this baby's lungs are small, this baby has got chronic lung disease, he needs better recruitment, and they put him back on the ventilator for the next 1 month. The child stayed oxygen dependent for another 2 years, and then came back, and today, unfortunately, is visually blind and has got developmental delay. A big lesson we learned here. We at that time realized that what we did wrong was we were inappropriately ventilating these babies. The initiation of ventilation itself was wrong in this baby, and we are doing improper things at that baby. But a lesson learned nevertheless, and as Satyan pointed out, we started at that time, 20 years back, started using the TPs and saying we have to be gentle on the baby's lungs at the time of birth itself. If it's a preterm baby, we have to use, if possible, an air oxygen blender. But that time, mind you, there was no concept yet of an air oxygen blender. Neither were blenders available in this country. So we would use 100% oxygen through a T-piece ventilator to a T-piece resuscitator. Yes, we had started hearing about permissive hypercapnia. And at that time, we realized it's not only about ventilation, it's not only about surfactant, it's also about preventing infection. We were letting go of babies dying due to severe Klebsiella and Pseudomonas sepsis. I distinctly remember at that time my mentor, Professor Neena Modi, came for a visit to my unit. She said, Karthik, there are so many septic babies here, you have to do something about them. So that was the time we also realized that the reason why we were going wrong was we are using excessive fluids in these babies. Professor Anil Narang in 1999 visited my NICU saying, I want to come and see your unit. He was coming for a conference. He said, all your babies are looking very edematous, Karthik. There's something wrong, you have to use less fluids. At that time, the recommendations were start with 100 ml per kilo per day, then go on to 120, 140, not like today, restricted fluids. And around the same time data got published, there was a Cochrane meta-analysis suggesting you have to use less fluids. We were actually quite happy that we had been doing PDA ligations fantastically in the NICU itself. By then, we had done 24 PDA ligations for preterm babies. And we are in fact thinking of publishing it. But Dr. Narang made me realize that we are using too much fluids. So we started cutting down on fluids. We also started encouraging in utero referrals of mother. This was well known to us long back, well known to obstetricians as well. But there was a lot of hesitation. We had to persuade mothers, it's better to deliver in a tertiary care unit rather than outside and then transport a baby in. This was around the same time that we started thinking about synchronization, because data was available that if you do synchronization, there is better blood flow to the brain and lesser lung damage. So we would not know how to synchronize. So at that time, we would just sedate babies or paralyze babies. That is not something we would do today. But again, those are the days we didn't have any knowledge about these things, and we would do synchronization by giving muscle relaxants and sedatives. Around that same time, some add-ons to the standard infant star ventilators which we had, the pressure-controlled ventilations, were the star sync. Some of the old-timers may remember. This was a star sync apparatus. You would connect it to a ventilator. There is a Grassebes capsule, almost like a skin probe of an incubator. It will go to the abdomen, get stuck there. So the minute the baby takes a breath, the ventilator will sense it and then give a positive pressure breath to the baby. So it was like a partial synchronization. Yes, a lot of data is published using the star sync, and this is what we are so proud about at that time, trying to do synchronization. This is about the time in the late 90s I thought we need to retrain ourselves. My philosophy all along has to be to learn whatever, unlearn whatever is wrong, and retrain myself. So I had a great opportunity at that time to have some more role models mentoring me. Professor Vinod Bhutani, I spent a lot of time in his unit those days and learned more about synchronization. Professor Bell from Iowa was doing only high-frequency ventilation for preterm babies, even as a early primary modality. I was quite surprised that he was doing it. And Professor Wong in Columbia, in New York City, he was sitting in the middle of New York City. Everywhere around him, people are talking of high-frequency ventilation, liquid ventilation, whatever. And he's just sitting there with a device called bubble CPAP and doing it. I didn't feel so impressed about it. I said, what is it he's doing? So I came back and said, I must learn about high frequency further. And me and Arvind Shenoy went to Amsterdam somewhere in Utrecht Medical Center and learned more about high frequency oscillatory ventilation and thought, that's fantastic, we should do all this. But look how wrong we were. But nevertheless, we started and we used high frequency oscillation ventilation, more for term babies, but for preterm babies with PIE, that was like a great support for us. As the late rescue, we used it, and we are quite happy with it. Now data suggests that you can even use it early rescue if the MAP is more than 15. But all around this time, the sword of Damocles was on our head all the time. One slight decrease in the baby's vital functions or the baby becomes sick, we would always think about sepsis. We were become obsessive. I had become really obsessive about preventing sepsis. I tried everything, whatever we could try to prevent sepsis and treat sepsis. Around the same time, 12 neonatal units in this country, similar kind of thought processes were occurring. We all decided to get together and try some adjunctive therapies in sepsis. I was made the PI for a multi-center trial on the use of colony-stimulating factors in sepsis, trying to see whether this helps. We had a mentor in Professor Dharmapuri Vidyasagar who sponsored this trial for us, and we presented, I had an opportunity to present it on a platform at the PS meeting in Boston in 2000. We showed in that trial that it's of no use. GM-CSF does not work at all. It may improve the colony count, it may improve the neutrophil count, it may improve the child's gender condition transiently, but survival effects are not there. So we almost gave it up. At that time, a lot of units in this country were using colony-stimulating factors, but maybe in neutropenic septic babies, it would work a little bit, but there was no data. So we practically gave it up. An excellent study done by 3 institutions in Bangalore, ours, and St. John's Hospital and MS Ramaiah Hospital, spearheaded by Arvind Shenoy. We showed that IVIG also does not work. This trial was stopped during the midterm because it was shown that IVIG was not helping the babies, and this is published also in the end of 90s. So practically these 2 adjunctive modalities we gave up, but we started concentrating more on preventing sepsis. This was around the same time, 10 years down the line now, we decided we need more space, and people have started referring us more patients. This happens typically in the growth of an institution, and we started becoming better at looking after 800 grammars and more than 28 weekers, all because of good nursing care and good systems and protocols in place. Same time, a lot of data on surfactants came. We started realizing that porcine surfactants are better, natural surfactants are better. 2 doses are enough, 4 doses is not required, and we started using a lot of surfactant because it was available. So also all over the country. Even in India, there was a company which manufactured a local indigenous surfactant, but unfortunately it was withdrawn later. But nevertheless, affordability increased, insurance, reimbursements, and the guidelines were there, so we had to use surfactant. And even government hospitals started using. So things became quite easy. 28-weeker, 1 kilo, antenatal steroids, yes given, RDS, fine. This is the time we realized that synchronized ventilation IMV is better, but then we had the start sync ventilator, or if you don't have that, at least give IMV better than CPAP. 1 dose porcine surfactant and the baby does well. 18 years later, the child is doing fine. So this is the time we had, it was a good period for all of us who believed in trying to be gentle with the baby's lungs. This is also the time newer ventilators were available in the market. We could put to use what we are reading about. Internet had started by then. We started using synchronized devices. We started using all these new modalities like assist control, SIMV, PSV, whatever you have. Transport also became quite good. We became experts in transport. We could pick up babies from out of town. Look at these twins picked up from Coimbatore, 1 kilo, and today they are 16 years old, doing absolutely fine. We gave surfactant during transport and they're doing fine. Same time, we started learning a lot about the nuances of acute lung injury. Micro models like this, teaching sessions like this would suggest to us, it's not only about barotrauma. Right from the time you initiate ventilating a baby, the first breath itself, the baby's lungs get injured. There is proteinaceous fluid leaking into the interstitium, into the alveolar cavity, and the child is going to go from bad to worse. New surfactant synthesis is not likely to happen unless you clear this up, and the child is going to get from bad to worse. And this is when we started realizing we are starting to save smaller babies, but they're going to land up with BPD and chronic lung disease. So the open lung concept came about this time. Some of us got the opportunity to have workshops on this, publish more on this. We suggested PEEP is good, gentle ventilation, permissive hypercapnia. These were the kind of watchwords at that time, and high frequency oscillation if there is a need to rescue. CPAP, the first words of CPAP, mind you, came somewhere in the early 2000s. But then we heard about CPAP, we heard about bubble CPAP, we heard something that oscillation in the bubble helps better than just using PEEP alone. Not enough data to suggest. But what about the interfaces? Just not available. So we would start CPAP using an endotracheal tube like the one shown here. We would cut it to the distance between the tip of the nose and the tragus, insert it unilateral into the baby's nose. It would sit in the nasopharynx, and we would be delivering CPAP through a ventilator. Not the right thing to do. In today's world, we know a unilateral device like this, it has the maximum resistance. A lot of data has suggested that not the right thing to do. But then we would do CPAP this way. We didn't have blenders, so if a baby had to be used a bubble, some indigenous bubble devices were available, made in India at that time. We would use an oxygen and air blender to the charts available, and we would then have an oxygen pipeline and an air pipeline and flow meters available, and we would try to blend the oxygen and give. Because by now, we had started realizing oxygen is not good for the babies. We should keep the saturations. Those days, the target saturations were not very clear. We'll say at least try to keep it in the early 90s. Around the same time, we started realizing that CPAP, no doubt is good, but the synchronized IMV is better, that is the nasal IMV is better. And the same time, we would connect babies to the ventilator on CPAP. We'll adjust a little bit of positive pressure to the babies who are not breathing enough, and they would benefit by the additional suggestion of tidal volume improvement and better lung recruitment. Nitric oxide was the in thing then. Some of us went and learned nitric oxide in centers like Harvard. I had the fortune to go there. But then, what about the gas? The equipment came in. We got the ionosis easily available in India at that time, but the gas was just too expensive to import from Australia or US, wherever. So it took us nearly 1 year for me to get this nitric oxide. It was a hard task. It is probably one of ours was the first center probably in the country at that time to get nitric oxide. It was purified industrial grade nitric oxide, to which I must say till date it's the only nitric oxide which is being available, and we started using it. Of course, subsequently we published this data. Most of the data is on term babies with hypoxic respiratory failures. Preterms, anecdotally we started, but it was not recommended in preterms at all. So the concept of volu and barotrauma started happening around that same time, and this was a game changer. In 2006, many of the people sitting in the audience, my colleagues, we all attended a workshops by Martin Kessler at All India Institute. Dr. Devarari had arranged this. We realized volume guarantee ventilation is the way to go. We realized it is the volume which is causing the problem, it is not the pressure which is causing the problem. Once we had volume guarantee ventilation in place, we were using ventilators like the Draeger, we realized that slowly the weaning happens on its own, and we are much more relaxed about the babies improving compliance and not really bothered about the lung getting injured. So this was a game changer. But giving surfactant, treating so many small babies, ducti would naturally keep open. So this was the time drugs were not all the time available. Indomethacin was not available, oral ibuprofen was available, but many times it would not work. So one of the earliest babies we did a coil device in an 800 grammer was in the late 2000s. But now, in the recent past meeting I went to the US, I realized such coil devices, the amplitude device is now available, and people are suggesting it's a better form of intervention rather than ligation. So this is just by accident, we happened to do a coil device in 2006. All this while, the data on respiratory care in preterms has been the pre-antenatal steroid era. This is the time in the late 2000s when after a lot of babies had been given and it had become a guideline to give antenatal steroids, a lot of data was available post-antenatal steroid, and it was shown very clearly. The mother receives 2 doses of betamethasone in a preterm labor up to 34 weeks of gestation. Just give early CPAP if the baby has respiratory distress and early rescue surfactant, and you're done. And this is working well. We hardly therefore needed to ventilate. Subsequent to this, we started doing all babies even insure. You intubate the baby if there is a need. 50% of the times you don't need to intubate a baby if you're giving early CPAP. But then if you intubate the baby and do an insure, even at the age of 7 days or 36 weeks of post-conceptional age, the baby may not need oxygen or ventilation. It's better than mechanically ventilating these babies. Professor Colin Morley published his COIN trial around the same time, and he also showed that 50% of the times you don't need to intubate and ventilate these babies. So this translated into clinical working with us. We also tried to spend more time doing these kind of procedures, and some of us got the opportunity to present it at international fora, and we clearly showed in our theses and research papers published by students that insure works. Prophylactic surfactant was the support trial which came up, and we realized if you just in the delivery room do surfactant in a baby who is extremely preterm, you don't need to give surfactant or intubate the baby in close to 30 to 50% of the times. Caffeine was the drug which was then available in the late 2000s, and we realized it is a wonderful drug. Till then we had been using IV aminophylline, not a very safe drug to do. With caffeine, the therapeutic index being so good, we are so happy using caffeine. So the end of the decade, this is the third decade of intensive care we were doing, we had realized the endotracheal tube is out like an extraterrestrial. You would not need to ventilate babies, ventilate very rarely if at all, only do permissive hypercapnia. Occasionally you would still need to ventilate. You would ventilate if the baby had congenital diaphragmatic hernia, PPHN, exit procedure. We started doing a lot of exit procedures at that time, hypoxic encephalopathy, inborn errors of metabolism. Yes, you would need to ventilate, but not necessarily for preterm RDS. You would hardly need to ventilate. The early part of this decade, this new kid on the block arrived, the HFNC. I had an occasion to meet Ram, who's a close friend, in the beginning of 2011. He showed me his cannula. I said, what is this stuff? I mean, I didn't realize that it is going to become a mainstay of care, and he was doing studies on that. We realized that the oxygenation and the gas exchange occurs in high flow nasal cannula in the nasopharynx, but I said, how is it going to improve the child's atelectasis? And this was a basic concern most of us had, and we were writing articles about it. We were not convinced. So also the data suggested that the pharyngeal pressure delivered by the HFNC is not necessarily adequate, and it's very variable. A lot of us were very skeptical about using it. So we said, okay, in babies, and mind you, this was before the current data which has been published, we said in babies who are extubated from CPAP, that is deep wrong from CPAP, maybe we'll use HFNC. Maybe instead of giving head box oxygen in a pediatric patient, we'll use HFNC like in bronchiolitis. Maybe if the baby had recurrent apneic spells, we would use HFNC. So towards the beginning of this decade, we had realized that all these therapies have become more and more non-invasive, and we had caught up in this country. This was the international data which is available. People, and volume ventilation, of course, still stays. That's one good thing which has still stayed as far as ventilation concerned. And we had also caught up. More and more of this last 6 years, I've been doing ventilation workshops. I've been doing, instead of intensive care workshops, I'm doing non-invasive workshops. The same principles have held with most of us belonging to that era. No compromise on the quality of care, evidence-based practices, adapting, 5 minutes more, ma'am, and mentoring. This era has led on to greater digitization, better internet available, infinite possibilities, online training, teaching has happened. We have started using less and less of surfactant. In fact, frankly, 50% of the times you don't need to use surfactant. If at all, you would use it by the Lisa technique. Lots of surfactants are available, but we are still looking forward to the synthetic surfactant, which hoping most likely will get approved. Because if that is available, then the surfactant costs come down, the cost of production comes down, and you can use it much more in many babies. Cardiac ultrasound is helping us look after babies with PDA better. We also realized that the babies with PDA in a bigger baby, more than 28 weeks, means no harm, unless the baby is symptomatically this thing. Of course, targeted PDA, we would need to do echoes less than 27 weeks of gestation. So we started going more and more non-invasive. If there is a PDA, don't do too much about it unless it creates trouble. If there is a possibility in a high resource center, people like you should learn how to do lung ultrasound. We have stopped doing x-rays in babies. A baby is delivered with respiratory distress, we do a lung ultrasound, and we realize it is just fluid, it is not RDS, or even if it is RDS, we hardly have started doing ultrasounds. As pointed out earlier, we have started realizing that oxygenation has to be targeted. SpO2 levels of about 85% should be obtainable in preterms at the age of 5 minutes. We started realizing that 91 to 95% is the pre-ductal saturations we should target to. We started doing collaborative research, trying to see how can we make it better for babies in the periphery and in the low research situations. The warmers like this are going to help these babies being looked after better, even if they have respiratory problems in the periphery. Zero separation. More and more of us are aware it's better to keep the baby and mother together. And using less invasive modalities of trying to monitor these babies. Pulse oximetry has become so common. And in the past meeting this year, thanks to Satyan Lakshmi Narasimha's inspiration, we also had a paper on OSI. And we realized that if even in a peripheral unit, if you have simple pulse oximetry, you don't need to do blood gases. You can calculate the oxygenation index fairly accurately. It's got almost a linear correlation. We also realized that antenatal steroids giving to late preterms is important because the morbidity is high even in babies up to 38 weeks of gestation. The only thing we have not done in this country, and still I would look at the NNF leadership for this, is determine viability. I would suggest in a high resource situation, the viability can be of course individualized, maybe 24 weeks and above, because the data is there even in this country that immediate survival is good, though long-term survival is yet to be seen. But we need to develop a consensus in this country. So we have got now data that CPAP works. We also have got recent data, meta-analysis available that if CPAP is not working, you can try NIV. We have data that HFNC is not good as CPAP, but if the child has to be given a secondary treatment with HFNC, you can try it after extubation. Synthetic surfactant, we are all looking forward to it coming. In a low resource situation, maybe LMA mask may be available to give surfactant. Nebulized surfactant is something we are all looking forward to. Goat lung surfactant does not work, or probably we'll have to do more trials on that. Lisa is better than Ensure. And maybe nitric oxide in babies who have pulmonary hypertensive crisis we can use. BPD is not such a fear anymore. There's a lot of data now available that lots of these modalities can work in BPD, and we are not so scared of it. We are looking after smaller babies with less invasive methods, but then even if the BPDs occur, we have enough data to available. So if you now look at the history, I'm going to summarize now, of all the interventions done for respiratory support in preterms, the wheel has come a full circle. I'm reminded of that paper in 1970s, Gregory published on early CPAP in preterms, and Professor Devarari published from All India Institute in 1988 on early CPAP in RDS. We come back a same circle. If you have a baby whose brain is decent, good, and the baby has got a good respiratory drive, I think the answer is only to do CPAP. Most of the times you may get out without giving surfactant as well. So look at this baby 3 years back, 25-weeker, 500 grams, done all the right things in today's world which we would do. Gentle on the lungs, gave surfactant, porcine, and this baby, by the time was 30 days old, was in room air, was just feeding and growing. And these kind of babies, we recently had an occasion to even analyze them on follow-up, and they found we got a good kind of Bailey score, composite scores on these babies, especially if they were more than 30 weeks. Now, if you look at the optimized results in preterms, if you use all these interventions, you realize that you can get away by doing less. So the word is less is more as far as preterm respiratory care is concerned. This translates into much of the data which my colleagues like Murki have also published recently, saying that even in low resource situations, if this can be taken by organizations like our NNF, the paradigm has now shifted to less invasive forms of preterm care, along with other things, adjuncts like nutrition, sepsis prevention. We can get away by trying to treat babies more effectively. Preterms are still the most important cause of death in our country. This is the recent data which was published last year by multi-center cohorts. So if we were to apply this, you have a typical situation in this country. You have the haves and the have-nots. If we were to merge, I don't know how the answer is. If you were to translate this, we have increasing manpower which is available. We just need to bridge this gap. Babies are more dying in the public sector hospitals where the manpower, infrastructure, and the equipment is less available, and more is available in the private sector. So there has to be a need to try to merge this. We have enough trainees, but is that enough is the question. Do we need more trainees? We have enough learning modules, but is that enough? Or NNF is doing a lot of it. Maybe we should all join hands with other organizations and do this. But the challenges are going to be quite high. This last 3 days, I've been hearing only this. We have a great NNF leadership today, and we have great people, visionaries, neonatologists, which are available at the helm of affairs in the government sector. The question is, can we try to do some kind of thing? Probably the answer is public-private partnership, trying to get this also in perspective, that trying to do less for the preterm is better, doing other supportive care is good, and probably we can get away by trying to do this. So the dream for many of us is this, to try to see that every baby who is born alive gets a very good chance to live with an intact survival. Thank you so much. I'll end here. Thank you so much for this opportunity. Thank you.
So thank you, Dr. Karthik Nagesh, sir. So the navigation of more than 3 decades, nearly 4 decades of respiratory care. That was excellent, sir. Thank you so much. We'll do the honors to Dr. Karthik Nagesh.
Ladies and gentlemen, sir needs no less than a standing ovation for his more than 3 decades of journey.
Thank you so much. Thank you so much.
Thank you, sir.
Thank you.
We'll take it. Yeah.
Thank you. God bless you.
We'll get it to you. Thank you.
Thank you.
Yeah, I will take it. Ladies and gentlemen, let's welcome Dr. Santosh Bhargava sir,
Thank you, sir. Thank you.
Senior Neonatologist. May I request the Chief Organizing
For having me.
Chairman, Professor Dr. Indrashekar Rao sir, to escort the senior most neonatologist, Dr. Santosh Bhargava, to deliver the Sheila
Great job, sir.
Karan Madam oration. Please come. Welcome, sir. చేరిద్దాం బాబు చేరి కూర్చుంటారా